Hey there, welcome back to part four, the final chapter of the Notes on the Heart. And today we're going to learn all about the cardiac cycle, which is going to kind of bring together a lot of the different elements we've been talking about so far in the heart. And we're going to learn about some disorders related to the heart. So lots of fun stuff ahead for us today. So let's go ahead and get started. All right, so the cardiac cycle is basically just a way of looking at all the events, like everything that happens for one heartbeat. And so when we put everything together, we're going to look at the EKG, we're going to look at the valves, we're going to look at the heart sounds, we're going to look at um, the flow of blood, everything all together at once. And there's two terms we have to be really very confident with in our understanding when we talk about the cardiac cycle. And those are called systole and diastole. And so systole is a name for the contraction of the heart. So when a part of the heart is squeezing, so for example, like when the atria are contracting, they are in atrial systole. When they relax, they are in diastole. And so if you've ever looked at your blood pressure, you know how like blood pressure might be like 110 over 70 is considered to be a great blood pressure. That 110 is the pressure of your heart during systole. Actually, it's during ventricular systole if you want to be precise. So that's the pressure that the heart is making when it's contracting. And then the lower number, so let's say 70 in this case, is the diastolic pressure or the pressure produced by the heart during its diastole phase. So that's why you have two blood pressures. One is when the heart contracts, the other is when it relaxes. And that's kind of the range in which your blood pressure works. Great. So during a cardiac cycle, basically we find that there are both atrial systole and diastole and ventricular systole and diastole. Or that's a fancy way just to say the atria are going to contract and relax once, and the ventricles are going to contract and relax once. So it's going to be just one round of both sets of chambers squeezing and relaxing. This graphic shows you the entire cardiac cycle. So we're going to be focusing on the different elements of this cycle. But you can see that it's basically just showing you all the different places that valves are closing, blood is flowing, and what's going on in each part of the electrocardiogram. All right, so the first phase of the cardiac cycle is called relaxation. And so you can see down here it says start. Um, this relaxation phase is when all four chambers go into diastole. So every one of the four chambers of the heart, both left and right atria, left and right ventricles, are just going to relax. And what's interesting is that during this phase, this is when we see the T wave. So this is the T wave, and right after the T wave, the ventricles are going to repolarize, they're going to relax, they're going to allow blood to flow into them, the atria are going to relax and let blood flow into them as well. And so about 75% of your heart's volume is filled during this phase. And the reason for that is that the AV valves are open. The AV valves, if you remember, are what allow blood to flow from the atria into the ventricles. So what we see is if you start here, we have blood coming into the atria from the veins. And this is just blood that's already been pumped by the heart. So, in other words, as the heart has pushed blood out of it from its last heartbeat, that blood pushes blood back into the heart. And so some of that blood is just coming back in through the vena cava from the pulmonary veins and filling up these atria. At the same time, because the AV valves are open, we start to see blood that drips down from the atria into the ventricles, and they fill up about 75% of the way. So about three-quarters of them is already filled just by this. If you've ever done CPR, you know how like CPR, you just do chest compressions and it's able to pump someone's blood. The reason for this is that most of this filling is happening just on its own. You, when you do CPR, are just like compressing the chest to try to pump the blood out of the heart. So basically, you don't have to do anything to fill the heart that much. You just have to basically get it out. The second phase is called atrial systole. And so that's where we get up here. Atrial contraction begins. And so the atria begin to squeeze, they begin to contract in. And as they do that, the AV valves are still open, allowing blood to pump from the atria into the ventricles. And this is where we get our last 25% filling of the ventricles. So what's interesting is that if you had no atria, like if your atria just stopped working, you could still have a heart that works with about 75% efficiency. The atria's job is just to top off the ventricles and get them up to 100%. Now, this corresponds with our P wave. So before, when we had relaxation, that was during the T wave and afterwards when we had this kind of like lull. And then as we get to the next P wave, this is where the atria begin to contract. They go into their systole, and we're able to push blood into the ventricles. At the same time, the semilunar valves are closed. And this is really important because we don't want blood coming back into the ventricles that has already left the heart. So if you'll notice, our semilunar valves have stayed closed throughout this process. The third step is what we call ventricular systole. And this is where, now that we've filled our ventricles up to 100%, so they're completely full, we really can't pump any more blood into them. We want the ventricles to start to contract. So at this point, this is where we see our QRS complex, this big wave. All of a sudden, the ventricles, as their wall begins to contract, they start to push the blood, and this is actually going to snap our AV valve shut. So both of these are going to close so that no blood can go backwards into the atria. As these build up pressure, eventually the pressure is going to force the semilunar valves to open. And as the semilunar valves open, blood's going to go out into the arteries and leave the heart. And that's what we call ventricular ejection. It's going to be ejected out of the heart. During this part, this time, we're going to see the semilunar valves are going to be open, the AV valves are going to stay closed, and this is all represented by this QRS complex. And then even into what we call the QT segment, where this little flat line afterwards, that's how long this goes on for. Because the T wave is then going to be when this stops and we have the repolarization. So another way to look at this cardiac cycle is we can look at it all lined up with our EKG, and that's why this is such a great diagnostic tool. So during this resting phase before the P wave, this is where our atria are in diastole. Our ventricles are also in diastole, so they're both relaxed. When we get to the P wave, about midway through the P wave, all of a sudden the atria go into systole. They start to contract all the way to about the middle of the QRS. When we start the QRS phase, about the middle of this, when we get to this R peak, all of a sudden this is where the ventricles go from their diastole to systole, and they're going to be pumping blood through into the arteries. When we get to the T wave, partway through the T wave, all of a sudden we switch from ventricular systole back to diastole. This whole entire time, from this R all the way until we get back to the middle of the P wave, the atria are in diastole. So the atria only contract for a very short amount of time between P and QRS. The ventricles only contract for a very short period of time between about R and about middle to end of T. So this makes one cardiac cycle. And you see there's a lot of time where both of these, from this T all the way down and then coming back through here to the P wave, are in diastole. So that's why if you listen to your heartbeat, it's like thump thump, and with like a long pause, thump thump. And there's a good bit of pause in there. Even when your heartbeat speeds up, thump thump, thump thump, thump thump. There's a pretty good amount of break in there, because this is that time when the heart is relaxing and filling up with blood, and it gets filled about 75% of the way. All right, so speaking of heart sounds, hey, there's actually official names for the heart sounds, and those are lub with two B's and dup with two P's. And the reason why they pick these sounds is that the heart sounds don't sound exactly the same. They're like thunk thunk, thunk thunk. But the first sound is kind of like a longer sound, and the second sound is more short. So it's like lub dup, lub dup, lub dup. It's a very short sound, the dup. And the reason for this is that the lub sound, the first sound, is the AV valves closing. So if you remember, if you go back to our cardiac cycle here, our AV valves had to close first so that when our ventricles start to contract, that no blood can go backwards. So this is your lub sound, is when these AV valves shut right between the atrial systole and when we start into this ventricular systole. So right around the time this QRS complex is happening, this is where we have our lub sound. The dup sound is the sound of the semilunar valves closing at the end of the ventricular systole as we go back into their relaxation phase. So basically, here's what your heart sounds like. Lub, dup, lub, dup, lub, dup. And that's why you have the pause in between. So we usually say that our heartbeat, our normal heartbeat, is lub, dup, pause, because the lub and dup just tell you how long the ventricles are contracting. So really, when you hear those heart sounds, lubbed up, that's how long ventricular systole actually lasts, which is not very long. A heart murmur is described as any sort of abnormal heart noise that doesn't belong in that normal lubbed up pause sound. So a lot of times, heart murmurs are described as like a whirring or gushing sound. And the reason for this is that it's usually where there's a hole or a leaky valve where blood is going to a place it's not supposed to. So a lot of times, instead of being like lubbed up, it'll be like lubbed up, lubbed up, or lubbed up, and the sound isn't like normal, like it's supposed to be. Some of these can be very faint and it's hard to hear for them. I've listened to quite a few heartbeats, and I'll be honest with you, I'm not a pro. That's why I'm not a doctor. It takes a lot of practice to really hear these. All right, so this is showing you a nice little chart putting everything together. So we're graphing our pressure over time, and we put our heart waves, or sorry, our heart sounds in with the valves closing and the pressure. So if you look, we have a couple different things here. The pressure inside the aorta is here in red. This obviously goes up when the heart is in ventricular systole, and then it slowly drops off. If you look at the atrial pressure, the atria have a little bit of pressure coming in. But then when the AV valves close, they have this little mini spike drop back down. And so they kind of have like this little wave. But notice there's not a whole lot of pressure in the atria because they're very thin. But the ventricles, on the other hand, as soon as the AV valve shuts, so at that lub sound, all of a sudden they start blowing up and have a huge rise in pressure as they contract. It drops off. And then when those AV valves open and the semilunar valves close, that's when we get that dup sound. So this is kind of like this little switch. There is a little bit of a third sound, which is possible to hear, but this is pretty negligible. And then we go back to 0 from there. All right, so last little stop we're going to do here in our heart notes, heart disorders, different conditions you can have with the heart. The first one is what's called coronary artery disease, and we actually watched a video on this last week about building a plaque inside of the heart and inside of the arteries in the body in general. And that process of building up cholesterol plaques inside of your arteries is called atherosclerosis. Sclerosis, anytime you see that, that means scarring or hardening. And so literally this means hardening of the arteries because that hard calcium plaque starts to build up from cholesterol deposits. Over time, you start to accumulate these plaques, which can eventually become fatal if they break loose. Everybody has this to some degree, depending on their cholesterol level, genetics, age, diet, a lot of different things. But pretty much you can be assured that everyone has some amount of plaque inside of their blood vessels, but it's only when it gets to be a certain size and if it becomes unstable that it's dangerous. So as you build up these plaques inside your arteries, eventually they can lead to partial blockages. You may have heard people talk about this where they have like a 20%, 50%, 80% blockage in a blood vessel. As these blockages go up, because more and more of this calcified fatty material builds up from atherosclerosis in the arteries, eventually people can get this thing called myocardial ischemia, which means that an ischemia is like a partial blockage. And this just means that the coronary arteries are partially blocked, and so not as much blood gets through. And what this means is that the heart tissue is starting to kind of like suffocate. It's kind of starting to become deprived of oxygen and nutrients. And of course, this is not good for your heart. This weakens the heart. The heart can't do its job, but it also causes your cells to start to freak out because they realize they're not getting all the stuff they're supposed to get. And this can lead to this chest pain that's called angina pectoris. And basically, if you've ever seen like on TV, they'll always say, do not take if you are taking nitrates for chest pain, blah, blah, blah. Basically, what they do nowadays is when people have this chest pain from these blocked arteries, one of the easiest treatments is to give them what are called nitrates, like nitroglycerin, that help to relax the blood vessels, allow them to stretch, and allow more blood to get in around the blockages. This is a pretty common thing in older people. But it can be potentially dangerous. And when people start to get these chest pains, they start to look into maybe giving them like a bypass surgery, which you've heard of before. Now, eventually, so we started off, with this building up of this cholesterol, it led to these partial blockages, this myocardial ischemia, which, when if it's very small, is not a big deal. As it starts to become greater, it can become more significant, generally leading to this angina or this chest pain. And this chest pain can eventually lead to a myocardial infarction or a heart attack if these blood vessels become completely blocked. And this is kind of like the progression of like a lot of heart disease, is that you see that people start off small and become progressively worse throughout their life. Although sometimes we see it doesn't go that way. Sometimes people have atherosclerosis. They build up unstable plaques, and those plaques will break loose and lead to a sudden myocardial infarction, a sudden heart attack out of nowhere. And so that's why this is all very dangerous. So any plaque is dangerous, but generally we see in most people that this kind of follows a normal pattern. All right, so related to that, let's take a look at some pictures. So here is our myocardial, this is our ischemia. And you can see where there's plaque that's built up in the artery, and you can see there's hardly any blood flow getting through. So this artery right down here, this is going to be our left coronary artery. Looks like it's pretty blocked off. So what do? Well, the problem is that those plaques can cause blood clots to stick. So this blood clot that maybe normally could fit through this artery now maybe can't fit through as well because of these cholesterol plaques, and that's the danger. So the more of this plaque you have, the more likely it is that you're going to get a heart attack. Now, people can get heart attacks for no apparent reason. It can happen. But the more plaque you have, the more dangerous. And of course, if this blockage happened right here in this part of the artery, everything downstream from that would be deprived of oxygen, and we would have dead or dying muscle tissue. And this is what we call infarcted tissue. So that's where we get myocardial infarction from. It's just, the death of heart tissue. So how do we treat this? Well, a lot of times they'll do what's called a catheterization, where they stick a catheter into someone's femoral artery down in their leg. They'll run all the way up through the aorta, and they'll inject a dye, and the dye will go into the coronary artery. And by the way, I know this is a different coronary artery, and they can look through an X-ray machine and actually see, using this contrast dye, where the blood vessel is narrowed by the plaque. So they see the artery blockage site, and then what they can do is go through and do something called a balloon angioplasty. And this is where they stick a catheter in. So a catheter is just like a really thin wire. It goes into the artery, and they actually use a syringe to pump it full of air, and it expands a balloon. And this pushes this plaque out of the way, pushes it out to open up the artery, and now the artery is clear. Another thing they can do related to that is called stenting, and you may have heard of this before. They use a catheter with a balloon on it, and it has a metal stent wrapped around it. And so what they do is they stick the catheter in, they expand the balloon, which expands this collapsible little metal piece of mesh, and then when they pull the balloon out, it leaves the metal behind. So this metal will hold the blood vessel open so it doesn't collapse. It'll hold the plaque out of the way and allow blood to flow through. And they actually put a really cool coating on this that makes it so that your platelets don't stick, so you don't get massive blood clots, which is awesome. And then after that, they do another catheterization, and they look with the dye, and here everything's good. Another thing they can do is called a bypass, and you've probably heard of these before. A bypass is where they actually graft on another blood vessel. So they'll actually go into your leg, and you have, if you remember, blood reservoirs. You have extra veins down here in your legs. They'll take one out, and they like to use this vein called the saphenous vein because it's a superficial vein just under your skin that you really don't need. They'll cut it off, and if you remember, your veins all have valves, so the valves all point upwards so that they can carry the blood back up to your heart. They turn the vein around, so they put the inferior end or the distal end up here onto the aorta, and they hook the more proximal end down here beyond the blockage, and blood comes out of the aorta, runs through the saphenous vein backwards and down and past the blockage. So that way the upper part of the artery still delivers blood to the top of the heart, to the base of the heart, and then down to get towards the apex, we use this bypass. That's a single bypass. Here's a double bypass where if you have two blockages, you can either hook on two pieces of vein, or they can even reroute some of these extra arteries that you have, like the mammary artery that isn't really necessary in most people, and you can go right past the blockage. So they have lots of different creative ways. Of course, they have triple and quadruple bypasses. Congenital defects are things that you can be born with, and there's tons of these. I just picked three that I thought were interesting. The first one's called an atrial septal defect. This is where you have a hole in the atrial septum, or the wall between the atria. If you remember, we talked about that little hole that fetuses have before they're born. Sometimes that hole fails to close for whatever reason, or sometimes the atrial septum doesn't form correctly during development. And so kids that have this, they have some mixing of the blood between their atria, usually because the atria are under very low pressure and don't really hold that much blood. It's not that big of a deal. So if you've ever heard of someone who has a hole in their heart, but it's untreated and they just live with it, it's probably an atrial septal defect. Ventricular septal defects, on the other hand, depending on their size, are way more serious because the ventricles do most of the pumping. They're the heavy hitters of the heart. So, someone with a ventricular septal defect generally is more likely to need to have this fixed right away. It's more serious. Although, if it's very small, they might let it go. But these are usually pretty severe because under all that pressure, blood usually gets pumped from the left side over to the right. So some of the blood that's been oxygenated gets sent back to the lungs again, which is kind of a waste. And eventually they just aren't getting enough blood flow like they need to the rest of their body. A valvular stenosis, this is where a valve has some tissue that kind of blocks it off, and so it can't open all the way, and not as much blood is able to get through. And this can cause blood pressure problems, blood flow problems, and this is something that also has to be fixed. And it's a fairly common congenital defect, usually fixed by a valve replacement. Arrhythmias, there are two main types of arrhythmias that I thought was important to talk about. These are like where your heart rhythm is off for some reason. The first one is called atrial fibrillation. And what this simply means is that fibrillation means that instead of the heart contracting as one unit, it just kind of like quivers or shakes. So if you remember, we said that all those myocardial cells have to all work together to pump as one network, as one unit. So you have an atrial network and a ventricular network. If the cells kind of get out of their timing and don't get coordinated, it can lead to this fibrillation. And generally, this happens under stress and strain. So, like if the heart's under a lot of work, for example, like if someone's really stressed out, if they're playing a sport, if they're exercising, something like that. In people that have certain heart conditions, that can trigger them to have this fibrillation. Sometimes even just like being shocked or scared, maybe if you saw like a scary movie, this could happen. Very, very rarely though. So like I'm not saying don't go play sports or don't watch scary movies, but when this happens, atrial fibrillation, people usually won't feel well, but they'll be okay. They'll still be able to get around. And there's a couple different things they can do for it. They can shock the heart. So if you've ever heard like a defibrillator, they can shock the heart back to normal. Sometimes they give people beta blockers or other drugs to try to fix this. But because the atria only do like the last 25% of ventricular filling, it's not a huge deal. Ventricular fibrillation, however, can lead to sudden death from cardiac arrest. So basically, the ventricles in this ventricular fibrillation just start to shake and quiver and don't do a coordinated pumping. And so effectively, the heart does not pump any blood during this. And so this is why they keep the defibrillators around schools, at sporting events, and around different public areas, because when someone has ventricular fibrillation, you have to very quickly apply CPR and very quickly try to get them onto a defibrillator to shock and reset their heart. And it's really crazy. Just like, how like a phone or a computer might start to like malfunction and you have to like restart it. When you apply an electric shock to the heart with a defibrillator, it's just like you've probably seen on TV where they say clear and they use the paddles and they shock the person. All of a sudden, that shock will restart the heart's pacemaker and the SA node takes over and starts producing a normal sinus rhythm, hopefully. And it seems like that works a lot. So it's a really amazing little piece of technology. These are a couple different diagrams of some different congenital defects that I wanted to show you. So remember we talked about the foramen ovale, which became the that was like the hole inside of the fetal heart that's supposed to be there. If it doesn't go away when babies are born, we call this patent foramen ovale. And so blood crosses over from the left atrium over to the right atrium. And we get this like mixture of oxygenated and deoxygenated blood. You can also have problems with the aorta. The coarctation of the aorta is just where you have this little narrow segment and it just hasn't formed correctly, so blood has a hard time getting out of the aorta because it's so narrowed. Another thing you can have is this thing called patent ductus arteriosus. This is another fetal thing. There's actually a little duct that hooks the aorta onto the pulmonary trunk. And normally this is supposed to close up when a baby's born. If it doesn't, it causes blood to flow from the aorta back to the lungs through the pulmonary trunk. And that's not very good. And a lot of these babies that are born with these two conditions will often end up being what we call cyanotic or blue babies. They're born with like a blue color because they're not getting enough oxygen to their tissues and they have to have these things fixed pretty quickly. The last one is called tetralogy of Fallot, and it's called tetralogy. Tetra means four because there's four congenital heart defects found in this condition, and these all seem to go together for some interesting reason. Having to do with how the heart grows. But basically, these kids have a large ventricular septal defect. They have a stenosed pulmonary semilunar valve. So they have like a smaller than normal semilunar valve here in the pulmonary valve. The aorta is kind of stuck in the middle so that blood from both ventricles goes into it. And because of this defect, the blood all mixes. So the aorta is receiving this kind of mixed oxygenated and deoxygenated blood, which is, of course, not good at all. I had a student that was born with this a bunch of years ago, and she was apparently an absolute miracle baby. She was one of the first children to have surgeries and successfully survive to adulthood. And she was a really amazing kid. I think by the time she took my class, she had had like 20 heart surgeries. They kept having to, as she grew, put more mesh and material in to like block off this hole. They had to keep putting stents in to reopen her pulmonary valve. It was really crazy, but she was an amazing kid. And that's what's so cool about this is that even these like really horrible conditions we're able to fix. Oh, the other thing I forgot, the fourth condition was the right ventricle is enlarged. So they actually had to go and scrape out some of the tissue of her right ventricle to open it up and make it larger. So just absolutely amazing stuff. Well, congratulations, you've made it to the end. So hopefully you enjoyed this and learned a lot about the heart and you're ready to become a cardiologist someday. If you have any questions, hit me up in the comments. If not, we'll see you next time.